Welcome to this high-yield clinical simulation explainer. We're bypassing the fluff today and jumping straight into the third and fourth order pharmacology and toxicology intersections you absolutely need for a 270 plus score. Let's hit our first clinical vignette.
Evaluate this presentation. We've got a heart failure patient on maintenance inotropic therapy who's demonstrating acute gastrointestinal distress, those classic yellow visual changes known as xanthopsia, and a life-threatening ventricular arrhythmia with concurrent hyperkalemia. Your clinical evaluation here has to immediately isolate a highly specific, potentially fatal toxicity matrix.
So, what's your immediate next step in management? This scenario demands that you bypass standard reflex protocols to identify the definitive, targeted reversal agent for this specific toxidrome. You've got 5 highly competitive options in front of you. Think about the exact mechanism of the maintenance therapy and the specific physiological roadblocks it creates.
The interventional trap here is absolutely critical to recognize. Standard hyperkalemia protocols mandate the immediate administration of calcium chloride or calcium gluconate to stabilize the cardiac membrane, right? But administering calcium in the setting of digoxin toxicity is a classic and potentially fatal clinical error. Let's look at exactly why that is and how it dictates our management strategy.
The only correct intervention is anti-digitalis Fab fragments. Let's dismantle these distractors. Calcium is strictly contraindicated. It's going to exacerbate intracellular calcium overload, putting the patient at risk for an irreversible stone heart contraction. IV insulin and dextrose, they rely on the exact same sodium-potassium punk that digypsin inhibits, so your standard shift therapies will completely fail. Lidocaine doesn't address the underlying cellular blockade, and furosemide is just far too slow to reverse the immediate threat. You have to administer anti-digitalis Fab fragments first to uncouple the toxin and actually restore the pump's function.
Here's the exact mechanism explaining why those shift therapies fail. Digoxin drives inotropy by blocking the myocardial sodium-potassium ATPase pump. This effectively traps sodium intracellularly, which subsequently prevents calcium efflux via the sodium-calcium exchanger. The resulting massive intracellular calcium surge increases cardiac contractility. But the complete blockade of cellular potassium uptake directly causes the severe extracellular hyperkalemia we see in acute poisoning. It's absolutely imperative that you separate these clinical states regarding potassium. While hyperkalemia is the definitive marker of acute, severe digitoxin poisoning requiring immediate Fab fragments, concurrent hypokalemia, which we often see from loop diuretic use in these heart failure patients, actually sensitizes the myocardium. Hypokalemia frees up binding sites on the ATPase pump, drastically lowering the threshold for digitalis toxicity.
Moving to our second module, we have a patient treated for atrial fibrillation on a Class 3 antiarrhythmic, presenting with an insidious onset of chronic dry cough, progressive respiratory failure, and peripheral neuropathy. You need to instantly associate this presentation with a specific pharmacological profile characterized by a massive volume of distribution and an exceptionally long half-life.
Analyze the systemic adverse effect profile of this medication. Which of these 5 distinct baseline surveillance tests correlates directly with the pathogenesis of this patient's specific respiratory presentation?
The correct answer is pulmonary function tests. We are looking at amiodarone-induced interstitial pneumonitis. While LFTs, TSH, and ophthalmologic exams are absolutely mandatory surveillance for amiodarone's other systemic effects, only baseline PFTs address the direct pathogenesis of this patient's respiratory failure. The basic metabolic panel is just way too nonspecific to act as a targeted baseline screen here.
This brilliantly illustrates the multi-system reach of amiodarone, especially its profound impact on the endocrine system. Because of its remarkably high iodine content, amiodarone drives a very unique thyroid divergence. It can precipitate destructive iodine-induced hyperthyroidism, but it can also cause profound hypothyroidism through the Wolff-Chaikoff effect. This dual-threat physiology is exactly why routine TSH surveillance is an absolute clinical mandate. The crucial point here is separating the desired pharmacodynamics from the toxicity profile. Don't conflate imiodarone's primary mechanism, prolonging the cardiac action potential to suppress ventricular and atrial dysrhythmias, with its systemic tissue deposition. Its extreme lipid solubility means it concentrates in target organs over months to years. That's what drives the pulmonary fibrosis, the hepatotoxicity, and the neurologic cascades we just analyzed.
Let's jump into our final simulation. A bipolar patient on maintenance psychiatric therapy experiences massive volume depletion from acute gastroenteritis. This triggers acute neurological deterioration, specifically ataxia, coarse tremors, and confusion.
Concurrent labs reveal a rise in creatinine, confirming an acute kidney injury. We need to determine the critical intervention.
Based on extracorporeal clearance criteria, what is the absolute definitive intervention here? We're dealing with a dialyzable toxin, presenting with concurrent acute kidney injury and severe central nervous system signs. You have 5 options. Keep those critical thresholds for extracorporeal clearance in mind.
The correct answer is urgent hemodialysis. Under the established AIOU urgent dialysis framework, the combination of a massive lithium ingestion toxidrome presenting with severe neurological symptoms and uremic renal failure absolutely mandates immediate hemodialysis. Distractors like an IV normal saline bolus are required for initial fluid resuscitation, but they fail to provide definitive clearance in the setting of an AKI. Furosemide and Kayexalate are completely ineffective or contraindicated here, and observation is a fatal error. The underlying pathophysiology perfectly dictates this management strategy. Lithium's clearance relies strictly on the renal excretion boundary. When gastroenteritis causes profound volume depletion, the kidneys compensate by forcing the proximal tubule to aggressively reabsorb sodium. And because lithium is handled identically to sodium by the proximal tubule, it gets dragged right back into the serum. This precipitous drop in clearance is exactly what triggers the acute neurotoxicity.
To close out this simulation, let's execute a final high-yield integration. What secondary endocrine abnormality must be monitored in chronic lithium therapy? Beyond nephrogenic diabetes insipidus and the acute neurotoxicity we just covered, chronic lithium therapy directly induces primary hypothyroidism. This requires the exact same meticulous TSH surveillance protocols we discussed with amiodarone. Mastery of these pharmacological intersections and their systemic surveillance requirements is exactly what separates a passing performance from an elite 270+ score.